Welcome everyone this afternoon, and thank you for joining our web seminar. My name is Katie Vollrath, and I'm the TCD Clinical Specialist with Natus Neurology. Today's topic is TCD evaluation in patients with sickle cell disease. I'm pleased to be hosting today's session in conjunction with our education team and Bob Nelson. In a moment, I'm going to introduce you to our speaker and presenter, Ann Jones. But first, we need to go over a few housekeeping items. Today's session is being broadcast across the internet, which means the presentation can be heard through your internet speakers. During the presentation, I encourage you to write down and submit any questions you may have for Ann using either the WebEx chat box or the Q&A to either myself or actually send them to Bob Nelson. I will be moderating all of the questions at the end of the session after a brief pause. Now, I'd like to introduce today's speaker, Ann Jones. Ann has been active in the vascular field since 1978. She began her vascular career at Wake Forest Baptist Medical Center and worked there until she became the director of the vascular laboratory at Montefiore Medical Center in New York. During that time, Ann served as president of the Society of Vascular Ultrasound. She is a fellow in that organization as well as a fellow in the RDMF. Ann is highly qualified to discuss TCD evaluation of sickle cell disease, as she was a clinical TCD instructor, site visitor, and QA consultant to the original sickle cell research trial called the STOP study, stroke prevention in sickle cell anemia, and was also the clinical TCD consultant to the TWITCH research study. Ann has published at least 15 clinical TCD papers and has provided educational talks at conferences and specialty meetings. I just have to mention Ann is one of my vascular ultrasound and TCD mentors, and we are so proud to turn this session over to Ann. Ann, here you go.
Thank you very much, Katie, for those kind words, and thank you, everyone, for joining us so late in the day. I know you've probably been hard at it all day, and I appreciate you coming on board. Let's see if I can, I'm not yet seeing my slides. So today we're going to talk about using transcranial Doppler for evaluating children with sickle cell anemia. And this is an area that has been near and dear to my heart for many years. I first started on this, as Katie mentioned, back in '86. And Katie, I'm still waiting for my slides to come up. Let's see.
Ann, do you see them now?
No, I do not.
All right. Bear with us a moment, everybody.
There we go. Okay. So today we're going to talk about specifically TCD and sickle cell anemia. And you say to yourself, why TCD for sickle cell? Well, look at that face and look at that smile. This is one of the first little patients that I had, Samantha, in one of my clinical sites for the stroke prevention trial. When I first started doing ultrasounds on her, she was 6 months old, and she is now moving into high school. She has never had a stroke, and her biggest interest when she would come see me for doing her TCD was to show me the dress she was wearing that day and how it would twirl. And my goal in life was to make sure that Samantha was able to pick out her dresses and twirl and not have to have help getting dressed because she had had a stroke. Now, this application of transcranial Doppler actually impacts patient management. Much like we used to use, we have still used sickle cell for evaluating patients with subarachnoid hemorrhage, TCD directly determines what will happen with these patients. Prior to being able to use TCD, children with sickle cell anemia often required imaging studies, which of course had radiation, or cerebral angiograms, usually requiring sedation. So the addition of TCD has not only improved the management, but it has eased the impact of the diagnostic evaluation of intracranial flow. The great thing about TCD is that we can continue to monitor the status and monitor the impact of the treatment that has been initiated without causing any harm to the patient. The bottom line is, if a good TCD study is performed, we can use it to make these decisions. So that's why we're here today. So who uses TCD in the clinical practice? My experience has been that we have primarily worked with pediatric hematologists and pediatric neurologists. The neurologists treat the patients who have had strokes or try to prevent them from having strokes, and the hematologists manage the treatment using either transfusion therapy or hydroxyurea. So TCD documents intracranial flow dynamics in children with sickle cell anemia, and it identifies those at highest risk for stroke by documenting the ones who have increased intracranial velocities because the arterial arteries have been narrowed. It assesses the impact of transfusion therapy and other treatment options, including hydroxyurea, which is one of the drugs of choice today, and it is now considered the standard of care for patients with sickle cell anemia between the ages of 6 months and 16 years. Now, you will learn as you move those children from the age of about 13 to 16, they begin to grow. They become a little more difficult to evaluate because the bone area that we're insenating through begins to ossify, and it makes it a little more challenging, much like performing a TCD in an adult. So sickle cell anemia, let's just talk about that very briefly. It most commonly affects people of African, Hispanic, Mediterranean, and Middle Eastern descent. When we think of the age of the children we're evaluating, we want to keep in mind that young children have the highest velocities. Even their normal velocities with sickle in children are higher than adults. And children with sickle cell anemia, even if they're normal, have a higher mean flow velocity than children without sickle cell anemia. So you already go in knowing that because of their age and because of the fact that they have sickle cell anemia, that their velocities will be higher than what you have encountered in the past in evaluating adults. Now, we know that anemia causes them to have a low hematocrit and low viscosity, so that, in essence, you have to have 2 times the volume of blood flow to be moved to deliver the same amount of oxygen to the brain. So, therefore, the red blood cells have to work hard in order to deliver the oxygen to these children's brains. Now, very briefly, sickle cell anemia, in these patients, they have a distorted red cell, so that they have chronic hemolytic anemia, and cerebral infarction can occur when you have occlusive vasculopathy at the distal internal carotid and the middle cerebral artery. So stroke prevention is possible through chronic transfusion or other therapy, because in essence what we're doing is improving the quality of the red blood cells that are circulating, and therefore decreasing the chance of the child having a stroke due to this anemia. This is why we're actually using transfusion in order to be able to increase the number of red blood cells and increase the oxygen delivery to the brain. Now, this is actually an example of a carotid artery, which many of us are familiar with, but the same type of thing is occurring with patients with the hemodynamics of blood flow to the brain. They don't have plaque formation, but they actually have arterial wall thickening, which will cause the lumen of the vessel to be narrowed. And as we all know, when you narrow the lumen, you must increase the speed of the red blood cells to get through that area of narrowing. So in essence, what we are trying to do is isolate the area where the vessel has narrowed and be able to put a number on the speed of the flow at that point. We can also actually have an occlusion of a vessel because of the formation of a clot at the point of the narrowing, but we are primarily focusing on the hemodynamics and the increased velocity of flow at the area of narrowing. Now, let's go and move into talking a little bit about treatment for sickle cell anemia, and I'm only going to touch on this briefly. Bone marrow transplant offers the only potential cure, but as I'm sure you know, bone marrow transplant is not a viable option for a large number of patients at this point in time, so we're currently using the best option, which is hydroxyurea, because it decreases painful crises and the frequency of the need for transfusion. Hydrea stimulates production of fetal hemoglobin, which helps prevent the formation of sickle cells. So it keeps the red blood cells that they have healthier so that they can deliver oxygen to the brain. Of course, we all know that the primary risk of transfusion is iron overload in the liver and the heart, so this can actually cause damage to these vital organs. And then the patient has to go on chelation therapy to reduce the iron. So this is a disease that has many issues, and what we are doing is trying to diminish the impact of the sickle cell disease on blood flow to the brain, and also while monitoring the management of these patients as well. So let's talk about doing TCD in children with sickle cell anemia. TCD in sickle cell anemia, or the Stroke Prevention Trial in sickle cell anemia, was a study that enrolled 130 children between the ages of 2 and 16 years. These children were at high risk for stroke if the time averaged mean of the maximum velocity, or TAM, in the middle cerebral artery or the distal internal carotid artery, just as it bifurcates into the MCA and the ACA, was higher, equal to or higher than 200 centimeters per second. Now, we had to be able to replicate this on 2 consecutive exams. So you would bring the child in, do the study, and then a week to 10 days later, sometimes up to 2 weeks, you would actually bring them back and document that they had those same velocities at the same site, and then the child would be considered for randomization into the study. So they were either randomized for transfusion therapy or standard care, which was just basic monitoring and addressing pain crises. After 1 year with the study, we found that children in the standard care group had cerebral infarct. 10 children had a cerebral infarction, while only 1 child in our transfusion therapy group had a stroke. So obviously this was amazing, it was impactful, and the clinical alert was issued from the NIH recommending transfusion therapy to maintain the hemoglobin S numbers below 30%. So we essentially stopped the study and said all children who were in the study were now going to be moved into transfusion therapy instead of routine standard care. So let's talk a little bit about TCD basics. You're all familiar with this, I'm sure, but just to go over just a little bit. We're using low frequency because it provides the necessary penetration. So 2 megahertz transducer is what we generally use. We use bidirectional pulse Doppler because we have to be able to demonstrate the depth of insination, and we also need to be able to discriminate flow direction for vessel identification. So if we know where we're insinating and the direction of flow where we're insinating, this helps us to determine which vessel we're actually evaluating. The diagnosis is primarily based on waveform data, the time average mean of the maximum velocity. You're going to get tired of hearing me say that, or TAM, is the mechanism that we use for evaluating velocity. Samples are acquired at 2 millimeter increments, and we will go over the reason for this as I talk about the examination technique. And the addition of imaging documents anatomy, pathology, and vessel course and patency, but I'm going to tell you that I'm very biased, and I believe that using the non-imaging pulse Doppler is much more accurate and actually much easier to evaluate the entire course of the vessel than imaging, which I do believe sometimes causes us to not place the sample volume precisely every 2 millimeters along the course of the vessel. So wouldn't this be the perfect patient to be able to have all of these great windows that we can see illuminated through the skull? In essence, we are looking at the major openings that we would insinate with TCD, the natural opening of the orbit and the foramen magnum, and also, and you can hear my cat whining in the background because he just walked into the room and wants food, I apologize, and also the area that we primarily use, which is the area right above the zygomatic arch, which is the temporal bone area. And this is the spot that we use for evaluating almost every specific location for looking at the circle of Willis. We do not routinely use the orbit because we found when we were evaluating children for the stroke prevention trial that they really did not take too well to having the transducer placed over the closed eyelid with gel on it. So we found that for the routine evaluation for most patients that we did not routinely look at the ophthalmic artery or the carotid siphon. I will say that on occasion, if you had difficulty in being able to insinate through the temporal window, that we would actually look at the area of the orbit because sometimes there would be a carotid siphon stenosis, and we found that it could be helpful in helping us document that, but that was not part of the routine stroke prevention trial. Now, when we're talking about the temporal windows, you have to really pay careful attention to which temporal window you're insinating. They all look very similar, but if you're coming in from the anterior window closest to the eye or the posterior window closest to the ear, you're actually changing the angle of insination slightly, and that could actually impact the depth that you're reading when you're doing your study. So you have to make sure if your best window is not the middle window, but anterior or posterior, that you want to document that on your technical worksheet so that if someone questions your depth, you can say, well, yes, it was off a little bit because I had to come in very posteriorly or very anteriorly in order to document a good signal. So essentially what we're looking at is the circle of Willis. The circle of Willis is the arterial vascular ring at the base of the skull. It joins the two internal carotid systems and the vertebrobasilar system. So it joins the anterior and the posterior circulations. It is the most important source of intracranial collateral circulation, and it is the primary focus of transcranial Doppler. As you can see from the image, we can actually insonate most of the entire circle of Willis from the temporal window. So we're very lucky in that the children we're evaluating have fairly thin temporal bones, which makes insonation through that area a dream if you have been used to evaluating adults. You will find that this is one of the most wonderful things about doing TCD in children with sickle cell anemia. So what are the sites of intracranial narrowing in children with sickle cell anemia? Well, as I mentioned earlier, the intracranial internal carotid, or what we call the distal ICA or DICA, the proximal middle cerebral artery, which is just at the origin from where the internal carotid bifurcates or branches into the middle cerebral and the anterior cerebral. And these areas are the ones that require intense focus because the DICA and the MCA are the two vessels that we use for entering a patient into a study. Now, this doesn't mean that we're going to ignore all of the other findings that we see with transcranial Doppler, but it does mean that entry into the study requires velocities of 200 centimeters per second or greater in the DICA or the MCA in order to be considered for the study or for treatment. So when we think about the circle of Willis, we have to keep in mind it is a very small vascular ring at the base of the skull. If you were to go into an anatomy lab and do a brain dissection, you would find that the circle of Willis in an adult is about the size of a $half, and in children is smaller than that. So keep that in mind when you're thinking about insonating these vessels. On all the images that we show, it looks like that they're greatly divided by these communicating vessels and that they're very easy to evaluate. And in some patients, they are. But when you think about how close lying these vessels are to one another, a very small movement of the position of the Doppler sample volume, either anteriorly or posteriorly or inferiorly, can actually change the vessel that you're insonating. So I would say the number one cause for making a mistake when you're doing TCD would be that you're trying to sweep the beam of the transducer much too abruptly from anterior to posterior, and in essence, you're actually sweeping completely past the vessel that you're trying to insonate. So I would say be sure that you make very tiny movements with your positioning of your sample volume rather than doing big sweeping motions, and I think you'll find that you have a great deal more success in doing so. Now, the pulsatility index is something that vascular folks tend to use in other types of vascular disease. This is not something that we routinely used in the TCD study for children with sickle cell disease, although it was helpful. It helped us to sort of get an eyeball of what may be going on as far as changes in resistance to flow. But the pulsatility index is automatically calculated for you by the TCD instrument. It requires a clean Doppler spectral waveform, because if you're calculating the outer edges of the waveform or the envelope of the waveform, and you have a lot of background noise, or your gain is too low, or your gain is too high, then in essence what you're doing is taking all of that information and using it to calculate a pulsatility index, which will then be incorrect. So in essence, what we're doing is looking at a systolic to diastolic mean. And with all intracranial flow, we expect to see continuous flow during diastole. If we see abrupt changes in the peaks or in the amount of diastolic flow in these vessels, that automatically warns us either we're not on the correct vessel or there is resistance to flow upstream, and we need to pay much more careful attention as we're stepping the sample volume across the vessel. So the pulsatility index increases proximal to a stenosis and decreases distal to a stenosis. And while it is helpful, again, we still use the time average mean of the maximum in order to be able to make our calculations. Now you'll see the arrow showing the Doppler sample volume. And I would say another helpful hint is when you're first starting your study is to start with a very large sample volume, kind of like a continuous wave Doppler. That way you have the highest probability of picking up a signal. And then once you have identified the vessels and you figured out the relationship anterior to posterior, then you would lower your sample volume to the 4 to 6 millimeters to use that for performing your study. That can always be very helpful. So this is a typical normal sickle cell waveform, and I will tell you that this is a version of the TCD machine that is before the beautiful one that you have now. And so it looks a little bit more raggedy, but you can see how nicely the outline in the envelope follower is tracking the course of the waveform. You can also see that there is some background noise. And when I first started doing TCD, Dr. von Reutern from Germany said to me, the best way to get the perfect amount of gain is to look as though you have a few stars in the sky in the background of your TCD waveform. And then you will know that you're capturing most of the higher velocity signals that you need to incorporate into the waveform follower to be able to get an accurate mean. If you lower your gain too low or you raise your gain too high, you may actually be getting an inaccurate TAM because you're calculating background noise or you're undercalculating the velocities of the signals that you're getting. So it's important, and this is something that will come in time, and you will see as I show you examples of the TCD waveforms throughout the studies, you'll probably look at them and say, wow, they're way overgained. But if you'll look at the background noise, you'll see that there's just a tiny little bit of background noise. And we found from trial and error, trust me, trial and error, that that having enough gain was really important to be able to optimize the signals. Now you can see here that you cannot see the waveform follower on these particular vessels, but what I wanted to point out to you was that sometimes in these children there are lots of collaterals, particularly if they have lots of narrowing in their middle cerebral or their internal carotid artery. Just as when we're looking at patients with peripheral arterial disease and we know that they develop collateral flows, we also see collaterals intracranially. And I will tell you that when we first started doing the pilot study, one of the reasons that we decided that we had to take samples at every 2 millimeters was that we would track some of these collaterals thinking that they were actually the MCA or the PCA, and they were actually just large collaterals that were moving around the area of narrowing. So the traceability of the vessel and being able to document the larger waveform demonstrating the middle cerebral and then the branch vessels along the baseline is very helpful to making you feel sure that you're actually on the vessel of choice. So now that I've moved through very quickly sort of the background of the STOP study, let's talk about performing the TCD sickle cell study and go over some of the basics. Now, when we did this study, we would always measure the bitemporal head diameter, or the position right in front of the ears along the temporal bone, using calipers that we got from lens crafters. That is something you can do if you choose to. It is helpful because if you measure the bitemporal diameter, and let's say it's 120 millimeters, and you divide that in half, which is 60, that would tell you that that's where your midline is. So we know from experience that the internal carotid artery bifurcation, or the biggest landmark that we use for TCD, is about 10 millimeters from the midline. So we know that if your midline is at 60, that you would start seeing your bifurcation at about 50. And it's just another little helpful hint to let you know if you're really on the right vessel. You can get these calipers through medical supply stores, and they're usually called obstetrical calendars because that's where they're primarily used. But I think that you will see that children who are between the ages of 2 to 6 usually have head diameters of about 120, and then the kids that start getting up from 6 to 12, usually about 125. And then as you get into your older teenage kids, their diameters tend to be between 125 and 30. So you can just use that as a baseline. And when you're doing your studies, you'll see that this does hold true to form. Now, we need to keep in mind that young children have the highest velocity. Anemia with low hematocrit will cause them to have, higher moving red blood cells to deliver the O2, and minor changes in carbon monoxide will actually impact the velocity and the waveform shape. So you have to keep the children awake, and you have to try to make sure they're not crying, because as you know, when they start crying and start taking in these breaths, it will actually cause a change in their respirations, and you can actually impact the O2 levels. So keep them awake. Try to keep the room comfortably lit, but not so dark that they want to go to sleep. We actually found that if we put a video monitor and they could actually watch a movie overhead, that would keep them focused and keep them engaged and keep them awake, which is very important. You can also see that it's important to keep the ergonomics of the system in mind. You want to be comfortable. These studies are tedious to perform. You'll find that your shoulders get very tense and your hands get tense. So you want to be able to rest your arms on the head of the bed, because this gives you a little bit of extra relaxation and support. It also gives you access to the children's heads so that you can see what they're doing. When they start blinking their eyes a lot to create artifact, you can look at them and say, we can either do this the easy way or the hard way. If you cooperate, it'll take 15 to 20 minutes. If you keep blinking your eyes, it may take all day. And it's amazing how that makes them quit doing that. You need to be comfortable, you need to explain the procedure to the patient, and then you need to keep the room quiet but keep them awake. If the child comes for a sick child visit and they ask you to do a TCD on them because they're already there, you need to instruct the physician that that's not a good idea, because what happens is that their physiology is out of whack with fever, and this could actually impact the results of their TCD study, and you could actually overcall a child as being abnormal when they are actually normal. Okay, so let's go to the protocol. We're evaluating very small arteries. We're performing protocol exams on moving targets or little kids. We're striving to avoid false positives and false negatives because this will impact treatment. The results will impact and drive the management. So let's do a study. Again, we're going through the temporal bone. We're not using the orbit, and we actually do make a couple of measurements using the foramen magnum just to have a baseline for the posterior circulation and to see if it's carrying collateral flow. So the first step is finding a signal, and you'll start at the temporal bone. As I mentioned, it's probably a good idea to set your sample volume depth at about 50, to open the sample volume, and then to just spend a few moments searching, using not just your eyes as you look at the waveform, but using your ears. I find that when I first start a study, I tend to close my eyes and just listen, because that helps me to find the signal, and our ears can be very helpful to us. So how are vessels identified? Well, the insonation window, which is usually the temporal window, the depth of the sample volume, the flow direction of the flow. So is the flow moving towards the transducer, or is it moving towards the midline? The traceability of the vessel. How far can you actually track that vessel easily? The audio signal and the spectral waveform and velocity. Why do we emphasize TAM? Because the clinical management is determined by the numbers. And again, you can see this waveform looks very saturated, but you can nicely see the envelope tracker. You can see a few stars in the sky in the background, and you can actually see a hint of another vessel in the background as well. But we're focusing on the waveform above the baseline. Failure to optimize at every step may actually result in misidentification, as I mentioned, tracking a collateral instead of a main stem vessel. And the automatic calculation of the TAM requires multiple waveforms, I would say a minimum of 3. And sometimes it's difficult to optimize these small vessels, but try to capture at least 3 good waveforms in order to be able to get an accurate TAM. Now, how do you improve your accuracy? Well, you can do a few things. You can see that the waveform on the right, that the background noise is very low, so the gain has probably been turned down so low that we would actually be missing information that could be used to calculate the TAM. On the left-hand side, you can see there's a lot of baseline clutter, which could be another vessel or it could be turbulence. And the top of the waveform is actually cut off so that the envelope follower simply is confused and cannot track the waveform adequately. At this point, you would need to lower the baseline so that you had flow displayed in one direction and that you could see not only the peaks but the ends of all the vessels so that the envelope tracker can follow it carefully. Now, when you perform these studies, you want to be consistent. You want them to be repeatable because you're going to be following these children over time. You want them to be reliable so that you always carry your study through from the very shallowest point all the way through to the contralateral side. You want to follow a standardized protocol so that it can be repeated. You want objective data, which means the measurement of the TAM, the mean flow velocities. And we have well-defined endpoints, which are the numbers that we've talked about. So let's start with the middle cerebral artery. The MCA is the largest terminal ICA branch. It's the most traceable and most reliable landmark. It carries about 80% of the blood received by the cerebral hemispheres, and it supplies a very extensive area. So this is the vessel we focus on mostly. You can see from the origin of the middle cerebral artery where the internal carotid has branched into the middle cerebral, which is moving to the outer part of the head, to the midline of the ACA. You can see that the MCA is very traceable until it gets to the area of the Sylvan fissure where it actually moves upward. So we tend to just focus on what we call the main stem or the main trunk of the middle cerebral artery. We use the transtemporal approach, and once you have found a strong signal at a depth of about 50, then you decrease the sample volume to a depth of about 36 to 38, and you start recording. We record this as the first MCA, or the M1, and then we record at every 2 millimeter increments until you get to the area of the bifurcation. So you can see that we're tracking at the depths of 42, 44, 46, 48, and we continue to track until we get to where the internal carotid has branched into the MCA and the ACA bifurcation. So you continue moving towards the midline until you get your nice bidirectional signal, which would be the bifurcation at a depth of about 52. The middle cerebral artery is above the baseline, the anterior cerebral artery is below the baseline, and if you angle inferiorly, that signal below the baseline would actually be the internal carotid, which I'll show you in a moment. So this is the magical bifurcation signal. This is the signal you want to find. This is the signal you always go back to if you get confused. This is the signal you use to start with to be able to demonstrate flow in other vessels. It's the most reliable signal, and it has a strong forward and reverse flow component, but the depth, of course, must correlate with the head size. You can see that the bifurcation depth can be repeated at about 52 and 54 because of the size of the sample volume. As we continue to move towards the midline, you pick up the internal carotid artery, or the DICA. We continue to use the transtemporal approach, and we angle the probe towards the patient's skull, the bottom of the floor of the skull, or towards their feet, to pick up the flow as it is moving intracranially from the siphon into the brain and branches into the MCA and the ACA. Now, this is a very unfavorable waveform angle for insulating the internal carotid artery. So we will notice that it has a harsh audio quality, and it may actually sound turbulent. And the waveform characteristics, as you can see, as compared to the middle cerebral artery, it is a little more damped, but it still has a nice systolic upstroke and a nice diastolic component, although the audio quality tends to be much harsher. So if you look at the internal carotid versus the middle cerebral artery, you can see a difference not only in the depth, but also in the pulsatility index as well as the mean. The mean in the MCA is higher than the mean in the ICA. If you continue to step the sample volume towards the midline, you will pick up the anterior cerebral artery, but that flow is moving towards the midline or away from the transducer. So it has arisen from the terminal ICA and moved towards the midline. It's a very difficult vessel to follow for a very significant course, so you usually only get 1 or 2 measurements of the ACA before it angles inferiorly and superiorly, and it's out of range for being able to follow. The anterior cerebral artery, again, the mean is very similar to the MCA, but a little bit greater than the ICA. It can be tracked at about 4 millimeters from the bifurcation, and it is normally with flow direction away from the midline. But of course, if it's a collateral, we can see changes in that as well. So you go backwards to the bifurcation and find that as your landmark. And then you angle the transducer posteriorly in the same horizontal plane at the depth of about 54 to 56, similar to the bifurcation, and you will find the first segment of the posterior cerebral artery, or the P1 segment. Now, this is the segment that arises from the basilar artery, and it's the segment between the origin from the basilar and the posterior communicating artery. Now, we can really only follow the PCA for a couple of centimeters, because then it wraps around the brainstem and it sort of angles itself out of the ability to follow it carefully. Patients vary, but usually several steps, probably 2 to 4 steps of the PCA is adequate to be able to demonstrate that you have documented it and you have separated the anterior from the posterior circulation. And this is a typical posterior cerebral artery. You can see again that the mean is lower than the anterior circulation. The depth is at about 60, and it still has that nice systolic diastolic component, but the peaks are much lower than the anterior circulation. So you can follow that PCA deeper as you move from 52, 54 to the midline, and then you can actually get another bidirectional signal, which is another intracranial bifurcation, which is why we have to pay so much attention to how we're angling the transducer and how we're positioning it, because we want to make sure that the top of the basilar bifurcation, which of course would be deeper than the internal carotid bifurcation, is carefully incunated and documented. This again is merely to demonstrate that you have separated the anterior and posterior circulations and that you have actually tracked the vessels appropriately. So this is a helpful hint on being sure that your bifurcations, you pay very close attention, not just to the means, but also to the depths, because they will be different from anterior and posterior. So it's also known as the basilar artery bifurcation, or the top of the basilar, where you would get this bidirectional signal as well. All of this is being acquired from the temporal approach. Now we will also look at the vertebral basilar system, but very briefly. You have the child turn on their side, tilt their head, their chin to their chest, and then you position the probe at the base of the skull and angle like you're coming with a flashlight with a shining between your eyes. So it sort of comes out the top of the nose if you were visualizing where the ultrasound beam would be. So we use this suboccipital approach. We turn the child to the side, and then we will set the depth at about 74 millimeters, and we'll just acquire 1 or 2 signals just to prove that we have looked at the basilar artery. The basilar will have a lower mean flow velocity than the anterior circulation, but in some cases, if the basilar is serving as a large collateral pathway, it will actually be higher. Yes, Katie, did you? I just heard someone. Okay. So the bifurcation landmarks are the most critical ones to pay attention to. Always return to the ICA bifurcation. That's the most reliable landmark. Once that has been identified, look at the ACA bifurcation, where you're looking at both ACAs being incunated, and then return to the ICA bifurcation and angle posteriorly to look at the PCAs. The hierarchy of mean flow velocities is very important to keep in mind. You want to make sure that the middle cerebral in normal conditions always has the highest mean flow, followed by the ACA, the ICA, and the PCA. If you see a disruption of this, that should be an automatic sign that something is wrong, that there may be an area of narrowing that was causing flow to move from one side to the other, or for one vessel to be providing more flow because of a stenosis or occlusion. So before you complete your exam, you want to make sure that you have correctly identified and labeled all vessels. You want to make sure you've documented all the pertinent data, that you have identified all the vessels, and if you haven't, you have to write down why. You know, the child just could have been difficult. Is there side-to-side asymmetry? We normally expect under normal conditions for the MCAs to be very similar, the ACAs as well, and we expect to see this hierarchy. Are the waveform characteristics what you would expect? And is the flow direction and the mean flow velocity within the limits you would expect? So the Pediatric Tcd Protocols, we look at the M1, the MCA, the bifurcation, the ACA, the distal internal carotid, the posterior cerebral artery, and the top of the basilar showing the midline. All of these can be incunated from the temporal approach. So what do you do with all this information? Well, you want to save the highest recorded velocity in each intracranial artery. Now, my rule is once you've gotten a signal to save it. You can always discard a signal. You may not be able to get it back. So whenever you get a nice waveform with a high velocity, save it for review later. If you want to look at their hematocrits, you may want to write that down each time the patient comes, because if there was a change that was not necessarily a stenosis, but a change, it could be just because they were closer or farther away from having had a transfusion, and this would have impacted their hematocrit. A mean flow velocity of 140 centimeters per second indicates increased cerebral blood flow without focal stenosis, so that would be considered normal. It's also important to look at asymmetry. You can see here in this very old slide that we have definite asymmetry from the left to the right, and that would tell me I needed to go back and look harder to make sure I didn't have a stenosis or an occlusion that I might have missed. So how do we interpret our findings? If we have a mean flow velocity in the MCA or the ICA of less than 100 centimeters per second, that's classified as normal. If we have a mean flow velocity that's greater than or equal to 170, that's called conditional, which means you will need to go back and follow them probably every 6 months to see if they change. If the mean flow velocity, or the TAM, is greater than or equal to 200 centimeters per second, that is considered abnormal. All abnormal findings must be repeated so that you have 2 studies. Now, how do you measure very high velocities? And I'm going to tell you, sometimes we get into some velocities that are unimaginable in some of these children. And you can see here that it is very difficult to even differentiate the waveform peaks and the peaks systolic and end diastolic. You want to do your best to identify the highest velocity, increase the gain to optimize the waveform characteristics, drop the zero baseline to see if you can display the flow in one direction, measure the peak and the end. Sometimes you can't even let it automatically calculate, but if you can record that, you can manually calculate the TAM. Measure the TAM using the envelope tracking software, and if the tracking software is too confused by so much noise, change the gains just a little bit, and then sometimes you just need to manually trace what you believe is the waveform envelope so that your interpreting physician will know sort of what the findings were. So conditional findings, we found in the STOP trial that when we focused on the MCA and the ICA, we also sometimes found abnormal velocities in the anterior cerebral artery, and we would actually monitor them every 6 months as well, because sometimes they could actually become abnormal. And in some patients, depending on their presentation, they might actually treat them with transfusion therapy. If you have increases in the ACA, the PCA, or the vertebral, it may not be a focal stenosis. It may just be a global increase throughout the entire course of the vessel that indicates collaterals. And so I would say to you that we've covered an awful lot of territory in a very short time, and I hope I haven't confused you, but the biggest name of the game is never compromise. And thank you so much for your attention, and I would be delighted to have any questions that you might have.
Thank you, Ann. At this time, I'm going to encourage you to send in your questions. We have a really unique opportunity here with Ann. She has so much experience, and I know that some of you are absolutely only doing TCD for sickle cell. So please take this opportunity and ask Ann your questions. And we've already got one question from Matt. Okay. He is asking if you could explain just a little bit more about the PI, or the pulsatility index.
Yeah, well,
et cetera.
Yeah, well, I can tell you that in the STOP study, we actually did not use the pulsatility index numbers. I know that they're used a lot when we're looking at renal artery stenosis and many other areas of vascular disease. We mainly used the pulsatility index to indicate whether we felt like there was resistance to flow downstream. And that was helpful because if you saw a very rapid upstroke in systole and you saw very little flow in diastole, then that would tell you that there was an obstruction to flow beyond the point where you're measuring. And you may have actually missed a stenosis that you didn't realize. So I would say that if the PI is asymmetric from side to side and out of whack, then you may want to go back and make sure you haven't missed a narrowing or maybe gone off on a collateral that would be a much smaller diameter vessel that may have a different PI.
Ann, can I just ask for clarification there? And you may not know this since that wasn't a big focus of the STOP study, but in adults, we consider a normal pulsatility index to be 0.8 to about 1.2. Was that applicable in your children?
Yeah, we would usually just use 1 as our normal PI, 1.0,
okay.
And anything below that we would be a little suspect. But like I said, we just didn't use it that much as a basis. I mean, we would sort of use it as part of the global comparison. And I would say that if your PIs are very different from side to side, again, you want to go back and make sure that there's not something you've missed or that you've gone off on some branch vessels, because some of these branch vessels can be very long, but they're usually much more narrow and much more tortuous than say the MCA or the ACA A1 segment. So if you're finding that they're harder to follow, then chances are you may actually be on a branch, and your PA may be an indicator of that. PI, I'm sorry.
Thank you, Ann. Here's another question. This is from Ramir. Is there a protocol sheet that he could download? Any thoughts on that?
You know, we actually did not, well, I mean, we had like what we called a worksheet where we actually looked at, you know, in one of my summary slides, if you go back and look at that, we just had the list of all the vessels that we made sure that we documented. So we would, you know, because the machine is so good, it's when you save your waveforms, that looking at your depths from 38 to 52 for the MCA, and then, you know, 52 to 54 to the midline for the ACA, and then inferiorly from the bifurcation for the ICA, we would just kind of use the waveforms themselves and the printout sheet that we actually had from the ultrasound machine. I think that probably if you get the New England Journal of Medicine article, which I'm sure we can provide that resource, we had those protocols listed in that, and that was just what we referenced.
Excellent. Okay, we've still got some time, Ann, so we're getting a bunch of questions in here. Okay. You may have addressed this, but maybe you need to reiterate it. Why was the treatment based on the findings in the MCA and the distal ICA?
Well, we just, yeah, go ahead, versus the other vessels.
Right.
We felt like that the other vessels were so much more difficult to optimize, and because the anatomy, let's just say the internal carotid artery. First of all, when you're looking at pathological specimens and historical information from angiograms, we found that the majority of disease occurred right there, as we would expect, at the bifurcation of the internal carotid into the MCA and the ACA. Because we expect to find disease in areas of branches or curves, the siphon and the internal carotid bifurcation were the areas that we focused on. Because the ACA has such a variable course and can have a very different caliber even from side to side, we felt that we would be overcalling disease if we focused on the ACA, because we weren't sure what the angle of insonation would be for any portion other than the very origin of the ACA. And we felt like that the caliber of the vessel was so different in patient to patient that, you know, we might overcall it, just because if you were lowering the diameter of the ACA, obviously the velocity would be higher. Was the velocity higher because the vessel was small, or was it higher because we were getting it at a weird angle, or was it because there was stenosis? And if you look back at specimens and you know, all the autopsy information, they felt like they could most reliably diagnose disease at those points of the internal carotid where it branched into the MCA and the ACA, and the distal ICA before it branched. We did find occasional disease in the siphon in these patients, but not as often as you might suspect. And if you're looking at the internal carotid artery from the temporal approach and you're angling inferiorly and you increase your depth 2 millimeters, 4 millimeters, and you're picking up a lot of turbulent flow down there, then those would be the kids that I would probably say, we're going to lower the power setting on the Doppler probe to 10%, and we're going to put a little gel on it, have the patient close their eye, and see if we can put it at a depth of about 40 and pick up the siphon and see if there's disease there. Now, they did not necessarily treat those children, but these days, you know, with all of the interventional radiology procedures, sometimes they're actually dilating them, but, you know, I don't really have any experience with that.
Okay. Thank you. Let's see. This is a frequent question.
Okay.
How many exams, if I'm starting off new with doing the TCD on sickle cell children, how many exams do I have to do before I can become an expert or really feel that my exams are reliable?
Oh, boy. Well, I think we all have days where we feel our exams are not reliable. I know I still do. But let me tell you what we did when we did the stroke trial. We brought all of our TCD examiners, and they were not necessarily registered sonographers against my wishes, but we had some very good nurses, and we brought them down to Augusta, Georgia, and they spent 2 weeks with us. And we had didactic sessions every morning, and then we would have scanning labs every afternoon. So by the end of a 2-week session, they had done about 20 TCD exams. They had done them from start to finish, and we had sat down with them with their physicians, and they had interpreted them, and we had critiqued, you know, their technique and told them how they could improve and that kind of thing. When they went home, they had to send us 25 more studies, and we reviewed them. And if we found that they were getting it, you know, early on, we'd say you're good to go. Or if we found that some people simply struggled, sometimes we would make a site visit to help them out. So I would say the minimum is 25, the maximum is infinity, but I would say after about 50 studies, you should be feeling pretty good about it.
Okay. That's some guidelines then that people can aim for. Okay, we still got more questions here. My physician, interpreting physician, suggests that I try to keep the child awake. I don't understand. Why is that important?
Because if they go to sleep and their CO2 levels rise, then you're going to find that their PIs drop and you're going to be underestimating disease. So you need to keep them awake just to keep their physiology in what we used to call a steady state so that they're breathing normally and that they don't have a lot of CO2, which will cause their vessel. So if they go to sleep, sometimes it'll go down. If they go to sleep, sometimes if they're breathing odds, then they'll go up. And what happens is if your CO2 rises, then you actually vasodilate, and that will actually increase the mean flow velocity. So you could actually overcall or undercall disease based on what was happening with the child's physiology. So that's why we encourage you to keep them in a steady state. And, you know, sometimes these kids get restless, and you'll do one side, and you'll say, okay, let's sit up for a minute, or turn on your side, and we're going to go ahead and do the posterior circulation, and then we're going to do the other side. I also found it was helpful that, you know, if they had the remote control, I could let them hold the remote control and say, okay, now you get to push the up button, or now you get to push the down button. And that would keep them focused on helping me, and it would keep them awake.
Excellent, excellent. You know, I think that is all of our questions. So, Anne, we do thank you so much for that lovely presentation and the many tips for perfecting the TCD diagnostic exam in our sickle cell anemic patients. And we've got one more question here. I don't want to not get this in, but then I have to make one more comment. Question from Max is it mandatory to do TCD through the eyes?
No, it is not. It is not. In fact, we didn't use it at all because we just found that it didn't add that much information except on the occasional patient, and the children just didn't like it, and it was better to be able to err on the side of getting a good transtemporal view than it was to get them all upset and crying and not be able to do that. So we just decided after the original pilot study that we were not going to do the orbital approach.
Makes sense. Okay, last comment. We did have one question of would this be available for replay? And yes, it is. Our past TCD webinars are available now on the Natus Neurology YouTube channel. Please note you cannot receive CMEs for watching these videos, as these are only for reference or refreshing. So to get your CME, you had to be attending today. If you do subscribe to our YouTube channel, you will receive an email notification every time we add a new webinar. So you can find us by searching Natus Neurology on the YouTube. Now, it generally takes a couple of weeks before we get these posted. So, for instance, Anne's presentation today will probably be available in about 2 weeks. And also, for those of you that are looking for your CMEs, we usually give people about that amount of time, 2 weeks, to get their surveys in. I'd love for you to go ahead and send them in, but we always wait for the stragglers. So if you don't receive your CME tomorrow, that's why we wait about 2 weeks. So again, folks, thank you so much for your attention and for joining us today. We expect to be having another webinar sometime in the spring, so please feel or plan on joining us then. Thank you so much.